food and then go ahead and settle in because I do want to make sure we give our speakers time today. We're really excited. Um, so we have Dr. Nikki Gentile and Dr. Janna Friedley here. I will give a brief intro for both of them, and then they are here to talk to us about long COVID. So thank you both for being here. Dr. Gentile is an assistant professor in the Department of Family Medicine and Laboratory Medicine and Pathology, and is the primary care medical director of the Post-COVID Rehabilitation and Recovery Clinic at the University of Washington. She is a practicing family physician and long COVID specialist. Nikki's research centers around investigating long COVID-related pain and potential treatments, including a clinical trial to explore acupuncture treatment for long COVID with the Osher Center for Integrative Medicine. She is a site co-investigator for the CDC-funded INSPIRE registry, a multi-center longitudinal cohort examining predictors of long-term consequences of COVID-19, and co-leads an AHRQ U18 grant to improve care access for underserved patients with long COVID. She is a sought-after speaker at national forums and was recognized by the National Academies of Science, Engineering, and Medicine as a long COVID frontline clinical expert, recently participating on the panel to assist in redefining long COVID. And then our other speaker, Dr. Janna Friedley, is a board-certified physiatrist, clinician scientist, professor, and chair of the Department of Rehabilitation Medicine at the University of Washington School of Medicine. Dr. Friedley received her undergraduate degree from Stanford University and her medical degree from Oregon Health Sciences. She completed her residency training in physical medicine and rehabilitation at the University of Washington. Following residency, she completed her MSTP K-12 fellowship, focusing on health services, research related to low back pain. She also received her Master of Public Health from George Washington University in 2020. Her research career has focused on conducting patient-centered outcomes and comparative effectiveness research related to chronic pain conditions and disability. She has received funding from the NIH, DoD, AHRQ, and CDC for a wide range of research studies, including research related to back pain, limb loss, and most recently, long COVID. She also has served as the editor-in-chief of the PM&R, the official journal of the American Academy of PM&R, since 2019. She is currently the vice, oops, sorry, lost my spot here. She's okay. She's currently the vice chair of the Washington State Health Technology Committee. She has an extensive record of grant writing, peer review, and editorial experience. And in 2020, she shifted her clinical practice from limb loss rehabilitation to found and direct the UW Medicine Post-COVID Rehabilitation and Recovery Clinic, which is the only multidisciplinary long COVID clinic in the state of Washington outside of the VA system. And she currently serves as the executive director of the UW Medicine's Post-COVID Rehabilitation and Recovery Clinic. So thank you both.
Awesome. We have slides. While we're getting the slides up, can everybody hear me? Is this okay? Great. I just want to say something really quickly about our name. We are currently in a name change. We did receive funding for $5 million through AHRQ for the next 5 years, and we are working on changing our name and becoming an official center of excellence, one of 9 in the country. So you may hear various names being dropped. The original name is Post-COVID Rehabilitation and Recovery Clinic. We are working with UW branding right now to figure out what our official name is going to be, but under our grant, which is what this educational opportunity today is under, we are the COVID Aftercare Recovery and Support, or CARES Center. So you may hear both, or Post-COVID Clinic. Okay. So let's see, is this working? Oh, wait. Okay. Some of you may have received a pre-talk survey, mostly those of you who pre-registered for this. If you have not done this, including those of you out in Zoom land, please do this. It will help us a lot with figuring out if what we are teaching about is helpful for you, and then we can edit whatever our future talks are. And I am very much aware that the date on this says February 2nd. Please ignore the date. My amazing research scientist is on much well-deserved time off this week, enjoying the March Madness festivities, and she is much better at REDCap than I am. So ignore the date saying February 2nd for both the pre-talk and post-talk surveys, but do complete these. They are very helpful for us, and we use the same tool across multiple talks that we do. We don't have anything to disclose other than the fact that we got a nice grant recently that we'll talk about at the end. The purpose of today is less to discuss specific treatments that for this condition, but better help you learn to manage it in your own clinic. It is a really complex condition, so we will touch on various points for the complexity of care involved. And also talk about some patient perspectives and resources that you can use. To start this, we'll start off by a case, and I bring this up mostly because each of the bullets on here represents a component of this complex condition that we'll touch on today. Everything from helping you work through work accommodations for somebody and what symptoms people are experiencing and how it may be impacting their quality of life. So this is pretty typical example, 45-year-old woman with diabetes with COVID about a year ago. Initial symptoms were pretty mild with URI symptoms and GI symptoms and fatigue for a few days. She initially recovered fully to baseline, but then developed some odd symptoms about a month later. And she now comes to you with 9 months of fatigue and myalgias that are worse with any exertion, tachycardia with heart rate up to 130 just while walking to the kitchen. Shortness of breath, a strange buzzing sensation that she finds very difficult to describe, brain fog, and new food sensitivities. She is unable to work full time due to her symptoms, and she is really worried about finances and wonders if there are any accommodations that could be put in place. She feels pretty anxious that she'll never recover, and she reports to you that clinicians she has told about her symptoms previously have all kind of brushed her off and said that what she's experiencing is not real. So this is just a word cloud of some of the symptoms that we commonly see. There's over 200 symptoms that have been reported in the literature. These are just a few of them that to highlight, and by no means is this an exhaustive list. But really the point I want to make here is that these symptoms are really interrelated. And usually this is not a primary organ issue like a heart or lung problem, but it's more of a systemic issue. And it's really important that we take a whole person care approach to manage the complexity of this. And because many of us are family medicine, it is important to note that this does happen in kids. All of the symptoms can happen in kids. Much of what we're talking about is relevant to kids, and I'll try to touch on a couple of things throughout. So why does this happen? We know a little more now than we did a few years ago, but starting with the entry of the virus into the body and into the cells, it does create this massive dysfunctional hyperimmune response behind the scenes and leads to all these downstream issues, some of which may involve blood clotting and endothelial damage, autoimmune issues, microbiota dysbiosis, and there's also some thought around neuroinflammation occurring. And then even more recently, we've got a paper that came out in Cell that talks about serotonin's involvement. And here, when a virus enters the body and there's chronic inflammation involved, this decreases tryptophan absorption and thus in turn decreases serotonin. And serotonin is needed for a number of bodily functions, including gut and also brain. And so the vagus nerve is involved, and some of this we think may be part of the reason why there are cognitive and memory issues with long COVID. And I bring serotonin up because maybe this could be a mechanism that we can use for treatment, targeting treatments. And then in thinking about something that none of us are strangers to is we know in primary care that managing complex chronic conditions does not involve only biological problems, but also just in general, the biopsychosocial profile is involved. And this is really important. Long COVID should be considered the same. It is technically a chronic complex condition. And we need to be thinking about everything from somebody's genetic predisposition to what else in their life is impacting them, from their stress levels to the environment around them. And sometimes thinking about this model can be helpful with counseling patients on, how they're doing. And it's not just any one thing that is contributing to some of the issues that they're experiencing. And then just back to this word cloud, not just because I love the colors in it, but also just to point out that it is not just the symptoms, but keeping these symptoms in mind, how is this actually impacting the patients? So a study we recently completed, funded by the Royalty Research Fund Award here at UW, we looked at over 1,000 patients that were referred to our clinic and seen at least one time in our clinic and reported having pain on their intake survey. And what we found is that 59% of these patients with pain associated with long COVID are reporting moderate or severely impacted physical function, and 80% are reporting moderate or severe fatigue. And this is based on Promise 29 scores in these domains specifically. We also saw both a clinically and statistically significant difference in PHQ-9, GAD-7, and PTSD scores in patients with long COVID associated pain versus those without pain. Something to note on here, though, is when you dig deeper into this, a lot of the time, the patients are scoring highly on the PHQ-9 questions that are related to physical symptoms. And so there is some question whether or not the PHQ-9 is actually the best measure to use. And some people think that maybe the PHQ-4 might be better, or even using the Promise 29 depression, anxiety domains. More to come on this later, but it's just something to keep in mind if you are, we screen a lot using these measures in primary care, and it may not actually be the best for this patient population. I do want to point out, though, and this is something that should not be ignored, is that 9% of these patients are actually scoring quite highly on the 9th question of the PHQ-9, the one that's pertaining to suicidal ideation. And that is something that is really important to note, because these patients really do need to be triaged and provided support. We also looked at risk of disability and self-efficacy scores, and we found that almost 2/3 of patients report low self-efficacy and that they don't believe that they can complete their daily tasks due to their pain. And almost half of the patients are at moderate or high risk of prolonged pain and disability. And then a remarkable number out of all the patients that we saw in the clinic, not just related to this study, but at the time that we looked at data for this particular study, is 81% of new patients seen in our clinic at that time when we pulled the data about a year ago, reported that they were unable to return to work at the full capacity that they were prior to having COVID, which, when you think about it, is a big deal with how this is really impacting not just patients, but the healthcare system and the workforce as a whole, and what this means in the long term. So COVID impacts people. Major impact on overall health and well-being. Behavioral health triage and support is important. It's also important to just keep in mind any ethnic and racial differences in outcomes that are important, as they may inform your clinical decision-making. And then working with panel navigators, there's a lot of evidence out there for complex chronic conditions that panel navigators and patient navigators can be helpful to reduce barriers and improve access to care. Some of you may have been at the department fair last week and saw my face blown up on the big screen going like this for this top bullet specifically. There's a lot of literature out there that actually says, please do not treat these patients in short visits. We are doing them a disservice. These patients have oftentimes, I hate to use the term, but have experienced medical gaslighting. They are coming to you after being seen by a number of specialists, being brushed aside, told nobody knows what's going on. And they often are also suffering in their work environment or school environment, and they really do need accommodations put in place pretty quickly. And so these visits really need to be longer to be able to properly counsel and provide the needed support. And just a note on the recovery for this. So this is a relapsing and remitting condition. And triggers are different for everybody, but work and school, because of the cognitive load, is often a common trigger for these people.
Thank you, Nikki. So I'm just going to spend a couple of minutes talking a little bit more about work accommodations, because this is one of the most challenging things that I think physicians deal with these patients, and it's a frequent cause for people to reach out to us to ask us for assistance. And I know it can be very overwhelming in thinking about how to approach work accommodations and disability paperwork, but just want to echo that this is really incredibly important that we do this for patients, and we help guide them through this. So hopefully we can provide you with a couple of really helpful resources for this. So just a couple of things to note is that long COVID is one of those challenging disabilities because it often is unseen. It's not a physical disability that you can necessarily see, so it can make it a little bit more challenging for people to advocate for themselves in the work or school environment. So that's one of the reasons why they need our help to do this. We know that with work accommodations and helping, we are able to get people back to work, and it may look a little bit different than it did before COVID, but we've been very successful in getting people back to work with accommodations and sometimes with temporary leave. We use a lot of energy conservation strategies that we'll talk a little bit more about to help people, and that's a lot of what the accommodations are about. I'm very fortunate that I work with vocational counselors in our rehab clinic. I know they're not necessarily widely available. UW does have some vocational counselors. We have them through our clinic for patients that are really struggling. And then recently, I'll just point out that we in March 15th, there was a UW Community Conversations that was a panel about rehabilitation for people with chronic diseases. And Joe Stuckey, who's one of our fabulous vocational counselors here at UW, he's been here for over 20 years. He provided just an amazing amount of information about return to work and resources for people. So if you're looking for a reference, that Community Conversations is posted on the UW website for Community Conversations, and you can refer to that. And then I do want to just point out that in 2021, long COVID was recognized by the ADA as a disability. So there are some built-in supports through the ADA for, oops, sorry. Okay, thank you. All right. So some of the most common work accommodations that we recommend for people relate to fatigue and brain fog, because those are the two of the symptoms that most frequently are impacting people's ability to work. So there are lots of things that you can do. You can adjust hours and time the work for when you have the fewest symptoms. You can advocate for more frequent breaks for avoiding prolonged standing and some flexibility between sitting and standing. You can ask for parking closer to the entrance so that you can limit the amount of walking that people have to do to get to work. Telework is a great option for people so that they don't have to drive and use their energy to do that and can focus on the work. And then you can adjust work activities depending on what it is. You can limit tasks that really require divided attention or multitasking, even changing the environment so that there's lower lighting, things like that can really be helpful. And so there's actually a lot that you can do to provide accommodations. And one really good resource for this is the Job Accommodations Network website. And this website actually has specific accommodations that are commonly used for people with various symptoms and various conditions. So this is a great resource for you to go to reference what those particular work accommodations are. And then one other resource that I think is really valuable is that through a Project Echo that Nikki will mention later in the talk, and there will be a link to it. There was a recent talk by Allison Sabrana, who's a patient advocate. She's someone living with long COVID, and she gave a fabulous talk about the impact of long COVID on her personal finances and talked a lot about community resources and the use of centers for independent living that are available in most cities throughout the United States, including here in Seattle, to help with work accommodations and other supports. So that's another great resource. She had a fabulous slide set that's up on their website that you can access as well. And on this Job Accommodations Network website, there's also some questions that you can think about as you're approaching how to help somebody think about return to work. So the questions that you want to ask to patients and think about are what limitations the employee is experiencing, how those limitations affect their job performance, what specific job tasks are problematic as a result of these limitations, what accommodations are available to reduce or eliminate these accommodations, and then how can you help the employer? What kinds of training that they might need to understand this? And documenting those things can be extraordinarily helpful for patients to advocate for accommodations and things that they might need.
What about the kids? Again, I promised I would bring up kids. So we're all familiar with IEPs and 504 plans. I do not want to spend time on the IEP, but I do want to mention that IEPs require the student to have one of the 13 specific disabilities listed under this act. And while long COVID can fall under this, particularly if it significantly impacts cognition and there's concern for this in the long run. But typically people are starting with a 504 plan, and that's really what I want to focus on. And so students will qualify for a 504 plan if they've got any physical or mental impairment that limits a major life activity. That includes school. So a lot of these kids with long COVID are really suffering in school. They are far from their baseline, and that's what we really need to be considering. And I bring this up mostly because a lot of parents don't know that this is an option, and it is initiated by the school system. So a typical evaluation team is really like the school administrator, counselor, teacher. Sometimes a psychologist is involved, in the student and the parent usually, but the parent consent is not required. And this is all about leveling the field for kids, right? It's an equal education opportunity. And a physician diagnosis is not actually required, nor does it mean that it automatically guarantees access to resources, but it is helpful in the evaluation process. And something that I didn't know, and I've been participating in a longitudinal 12-week pediatric long COVID echo series with a lot of the stuff we already do in our clinic, but the 504 plans and IEP stuff was really new to me. And I think that this is really helpful information. What I didn't know is that this follows the students beyond when they are in the public school system. And this is important because when you think about the number of patients that have adult ADHD that maybe went undiagnosed from when they were a kid, they did not get 504 plans, and therefore they cannot have the same resources through this Section 504 that they maybe would have had they been on a plan back when they were younger. And so it's important that we not forget about, while the students might be high achieving, if they are suffering in school, we really should be considering this because it can be helpful to them in the long term. Some other considerations. So COVID can really bring to light new diagnoses or worsening of underlying conditions. Some common ones that we see are diabetes, sleep apnea, thyroid disorders, iron deficiency, ADHD, and pain. Oftentimes it's fibromyalgia-like pain. And mostly what I find is that a lot of primary care docs are afraid to actually change people's medications after somebody's had COVID because they think that because COVID is causing something, they're worried that there's some other thing going on behind the scenes. That while we are still learning cellular mechanisms and pathophysiology, the fact of the matter is our toolbox and our specialty clinic is the same as yours. And so we should be thinking about adjusting people's medications. So maybe this means adding low-dose naltrexone for somebody's pain, or adjusting the diabetes medications. And oftentimes I find patients with underlying ADHD are significantly impacted on a cognitive level after having COVID, and they may need a slight bump in their medication doses, even if in the short term, while you're working on helping them obtain work accommodations and whatnot. And then the presence of other conditions does not exclude long COVID. Long COVID is tricky. There's not a unifying definition of it. And so it really is this umbrella of a number of conditions that can happen after having COVID. And that can be from primary effects of the virus, so someone maybe having pulmonary fibrosis, but also, worsening of their underlying conditions. And then diagnosing it can feel difficult, partly because of this waxing and waning definition, depending on who you're talking to. But we really should be making the diagnosis in primary care, and not doing that can be actually harmful to patients. And some of this, we are about to publish this paper. The Royalty Research Fund project I had mentioned before is a mixed method study. Chris Ma, who is one of our psychology postdoc fellows, really spearheaded this. And they did 7 focus groups with 25 patients that were seen in our clinic and reported pain. And I'm not going to go into great detail about the 8 themes that they found, because that's like an hour-long lecture in and of itself. But I do want to just highlight a few things that I think are important for primary care. The first being that the symptoms, that symptom word cloud, those symptoms usually don't just occur one by one by one. They really do co-occur, and taking that holistic whole person approach is important. Patients report that they find it incredibly difficult to receive a diagnosis, and this is harmful to them. That is what they have told us. And part of the reason why receiving this diagnosis has been difficult is because there's still a lot of people out there that don't believe this condition is real. And they are just it's not thought of or ignored. But also just because the difficulty in actually understanding the true definition of it, and it is kind of a definition in flux right now, it can make it hard to receive the diagnosis. But patients are perceiving this as being harmful. Sometimes they're reporting that their treatments that are being prescribed maybe are not in line with their overall goals. So we really should be looking at what is helpful to them. And what our patients in this study have reported are things like acupuncture, massage therapy, using wearables to track activity levels, and then also physical therapy, but not just any physical therapy referral. It's important to have an exercise prescription associated with it. And anybody is welcome to steal the dot phrase. I have an epic called Post-COVID Exercise RX. Please include that in PT prescriptions, because you don't just want to send somebody to PT, any PT, just with a diagnosis of long COVID. And Dr. Freely will talk a little bit about that. And then listening and validating to patients. This is probably the most important aspect as part of the patient's care. These patients really do also empathize with the fact that this is a new condition and a lot is unknown. And they appreciate when you sit there, if you don't know, and you say, I'm not sure, let's look at this together. And kind of all of these, oh, and I forgot to mention access to care, which we all know is tough in all elements here at UW these days, pretty much everywhere in the medical system. Hopefully we can improve that. So finding a delicate balance between validating symptoms and approaching care holistically, and being transparent and learning together, and evaluating common overlapping diagnoses, but making sure that we're practicing strong clinician stewardship with referrals and lab ordering. And who would I be if I didn't bring this up with my role in lab medicine? We should not be just ordering lab tests if someone asks us to order it, or if we're hunting for something. Really, if it's not going to change management, or we're not sure how to counsel on the result, we shouldn't be ordering it. And if anybody ever has questions about proper lab workups for this condition, please use the office hours that I'm going to talk to you about at the end. And then with patient-centered referrals, meaning going back to the fact that this rarely is a primary organ problem. Usually primary care is like the best place for these patients. We are well equipped to manage these patients holistically, and they often don't need specialty referrals. And so we should be thinking about what referrals we're actually using. And then refraining from needing to find the definitive answer and moving forward with helping the patients now. That might include getting them work accommodations so they can actually do well in their job. And then gaining comfort with the discomfort of making that official diagnosis. And this slide is supposed to help you, even though it is text heavy. I want to note that CDC, since the beginning, has basically said that long COVID can be diagnosed 4 weeks after the infection. We do not recommend that. The PASS Collaborative and the World Health Organization, we operate under the 12-week rule. And part of this is because most people recover between 1 and 3 months. And so if you're making the diagnosis too early within that general post-viral period, then you're labeling somebody soon, and they may not actually have long-term issues, and then that goes on their record. And this, you never know what is going to happen downstream, whether or not it impacts life insurance policies. I've had several patients actually bring that up, or insurance premiums or whatnot. So it is that careful balance again of where we need to make the diagnosis so the patients can access resources and get the care that they need, but keeping in mind the time frame. And so our referral criteria is continuation or development of new symptoms 12 weeks after infection and beyond. And then a lot of people ask, well, with the ever-changing test environment, how do you know someone had COVID? The Pan American Health Organization, these are the criteria that are often used in NIH clinical trials, and this is also how I think about it, is there's not just confirmed case of COVID, but criteria for probable or suspected cases. And this is kind of a good framework to go off of if you're wondering, did somebody have COVID? Do they have an acute COVID case now? And then if they've had the symptoms beyond 12 weeks, then we should be thinking about long COVID. And just a quick note that the National Academies of Science, Engineering, and Medicine, they convened a committee to basically redefine long COVID. And last year, there were focus groups and questionnaires that were administered. There was about 1,300 participants. I sat on the frontline clinician panel for this and spoke on behalf of our clinic and provided recommendations. And this QR code on here is the very long document that summarizes what came out of this, which you do not need to read, but it can be really helpful. Some of the information in there for counseling patients, and I'll highlight just a few things. So satisfaction or dissatisfaction of the current working definition really depends who you're talking to. Insurance companies are more likely to be more dissatisfied with it versus everybody else is kind of all over the place with how they feel about it. Common reasons for dissatisfaction are the definition is too broad, which we've already sort of touched on, and that it should include specific signs, symptoms, and conditions. So rather than just being this umbrella of could be anything, some of us have recommended maybe considering having different diagnosis codes for different phenotypes. So long COVID fatigue, long COVID pain, long COVID cognitive issues, so that's just one suggestion that we had. And then the 4 weeks is just not enough time. So that really is not used in the specialty clinics across the country. All of us on the panel really said that 3 months is a better cutoff. But we also talked about maybe redefining based on other timeframes and having certain weeks associated with it, depending on how far out they are from the illness. And then something that I think is really important, depending on who you're talking to. So clinicians and researchers are more likely to think that diagnosing this condition, it should be a diagnosis of exclusion, and that are less likely to feel that a patient's perception of whether or not they have long COVID should be taken into account. That is the opposite of how patients and caregivers feel. They really feel that their perception of whether or not they have long COVID should be primary reason for going into making this diagnosis, and it should not be a diagnosis of exclusion. We're clinicians. This is hard to hear because there are obvious reasons why maybe one versus the other is not, ideal in many cases. But I bring this up mostly because this is where your patients might be coming from, and it's important to be aware of this. Key takeaways from the NASM work is that more work needs to be done. It's never just as easy as they thought it might be. So that is currently happening now. I don't have any answers for you. But you're always, feel free to read some of the document just so you're aware. And this work is currently going on behind the scenes. Can this be treated? We do not have a magic pill. We don't have a single lab test, but people are improving and there is hope. Treatments, again, they need to be tailored. And we're not going to focus on specific treatments today necessarily, other than provide you with some resources that you can use in your own clinic. But we do have a patient education handbook that will be translated into multiple languages and published and accessible to you once that is out. I do not have a timeline for that, but we have been working on it a long time and hope that it's finished soon. For these 4 pillars, pretty much every patient that comes to see us, we are addressing these usually in the first visit. Making sure that we're talking about their sleep habits. Are they practicing good sleep hygiene? What are things that could be impacting their sleep? Are they drinking alcohol? What's their bedtime look like? Other stressors. Could they benefit from CBTI classes with Dr. Yamamoto? Maybe. My patients have loved those, by the way. And, could they benefit from pharmacotherapy? So it's general primary care stuff, right? And then making sure we're addressing their mental health and providing them with the appropriate support. Nutrition, this is a tough one. There's no evidence to support any one diet or supplement. That being said, some patients respond better to some diets and some respond to some supplements. It really just depends on the case. I've got a number of patients that feel better when they follow low histamine diet or low FODMAP diet. But in general, we're often talking about anti-inflammatory diets. And I find that our amazing integrative medicine specialists, Dr. Bell, Dr. Maj, are excellent resources when talking about supplements in this particular pillar. And then the tailored restorative exercise program, which I will save for Dr. Friedley to talk about. If you're wondering what's being studied, and if a patient comes to you and says, "Ooh, I would like a referral for hyperbaric oxygen," please don't do that. And you are welcome to go to NIH Reporter or clinicaltrials.gov to see if what the patients are bringing up, or if you're just curious to know what is out there and being studied right now. I highly recommend it. I bring up both NIH Reporter and clinicaltrials.gov because when you receive a grant, the information about your study, including your study abstracts, automatically going to go up on NIH Reporter, but there's going to be a lag time because you're given time to publish on clinicaltrials.gov. So you may not see everything on clinicaltrials.gov if something was just funded. Our acupuncture trial is a great example of this. I'm not going to go into this in detail. I'm not even going to explain what the color coding means because it doesn't matter right now. Just know that there's a ton of stuff being studied ranging from acupuncture to various drugs and supplements. So clinicaltrials.gov is a great place to look.
And I'll just take a couple of moments to talk a little bit about some ongoing studies that you should be aware of. So the RECOVER study is an NIH funded study that was started as an observational cohort study nationally. And so they really started looking at some of the longitudinal data for how patients were doing, but also doing some deep phenotyping to really understand the pathophysiology. So a lot of the work that's come out has been through the RECOVER network. They also set it up so that they could rapidly initiate a number of platform trials. That was one of the goals for the RECOVER network. And there are now 5 different clinical trials that are either ongoing or just about to start. And UW is one of the RECOVER recruiting sites, and we are participating in several of these clinical trials. So the VITAL and the Neuro clinical trial. And then I am co-leading the Energize trial, which basically is 2 trials in one under the umbrella of Energize, which is a cardiopulmonary rehab exercise trial for people with exercise intolerance and no post-exertional malaise or little post-exertional malaise. And then for people that have post-exertional malaise, which I'll talk a little bit more about, we are doing a pacing trial. And so that's being led by myself and Dr. Cindy Bateman, who I'll also mention a little bit later because she's got a great website with a lot of resources. So patients can enroll in these clinical trials. We always encourage patients, if they want to try something experimental or something that hasn't been proven, that if there is a clinical trial available, that's the best way to do that. So if you go to their website, you can patients can enroll in those trials. And then another resource I wanted to mention is the PASC. There's a national PASC collaborative. It's a multidisciplinary collaborative with over 40 different clinics represented across the country. And this group over the last several years has published a number of PASC consensus guidance statements on different symptoms that people are experiencing. And this has been work that's been done through the AAPM&R, the American Academy of Physical Medicine and Rehabilitation. And these have been published in the journal that I'm the editor for, PM&R. So these, I think, are really good resources as well for basic workups, treatments, and information about different topics. The one that one of the more recent ones that we published was on autonomic dysregulation. And this is a really important topic because many of our patients are experiencing autonomic dysregulation. So we're going to spend a little bit of time talking specifically about that condition.
Yeah, I really wanted to highlight this today because this is the most common curbside consult I get from our residents and faculty. And this guidance statement was actually one that I peer reviewed, and I think it's a pretty good one. Not that I'm biased or anything, but it is really helpful. So autonomic dysfunction, I would have to say that most of the patients I see have some level of autonomic dysfunction. It is incredibly common in this condition. This is a scary slide when you look at it, and it's a nice reminder of what we used to have to learn in med school. But you can't read this on the screen, it's too small, but this extended autonomic network over here on the left is just pointing out that there's the central autonomic network, the autonomic nervous system, the neuroendocrine system, and then the immune and inflammatory systems. I want to focus mostly on the autonomic nervous system today, which is the enteric nervous system, parasympathetic and sympathetic nervous systems, and their neurotransmitters associated. And just thinking about the anatomy, the main point here is that for both the sympathetic and parasympathetic nervous systems, every organ in your body is involved here. And so if anything goes wrong in this system, is there's activation or inhibition of components of the autonomic nervous system, you can imagine that because every organ is involved, pretty much any symptom you could think of that is related to long COVID could be happening, right? And so under this umbrella, this is just a list of some of the symptoms, the more common ones that we see, and this is not an exhaustive list, but anything from chest pain, shortness of breath. Remember, I said that usually this is not a primary lung or heart problem, right? A lot of the times it's actually an autonomic issue that we find. And then you also can see brain fog is on here, food intolerances, erectile dysfunction, sweating, temperature dysregulation. There's a lot of symptoms on here that are really common in long COVID. And then triggers, prolonged standing, warm environments. So a lot of our patients actually feel really bad in the summers. And then a number of other things, alcohol, stress. And then we do need to make sure that we're ruling out conditions that cause sinus tachycardia, in particular anemia, thyroid disorders, medications. And then, so how do we work this up? Typically in primary care, I recommend starting with orthostatic vital signs, but not in the way that we routinely think about them. So not laying, sitting, and standing, but laying and then standing after 2 minutes and after 5 minutes again. And so what we're looking for is a sustained change in the vital signs. So somebody who's got autonomic dysregulation, that their vital signs are going to be off and their heart rate's going to be elevated the entire time that they're standing, right? And so if you're not sure about the orthostatic vital sign results and you want something more sensitive, I recommend doing the 10-minute NASA lean test. This is where the patient's going to lay down for 10 minutes and then you're going to check blood pressure twice, 1 minute apart, and that's your baseline. And then you have them stand up against the wall, leaning slightly at an angle, and then you're going to check blood pressure and heart rate and monitor symptoms every minute for 10 minutes. This is sufficient for diagnosis. We do not typically need formal autonomic testing with a tilt table. We oftentimes find that the sweat test as part of that is not really relevant to this patient population anyways. It's costly, hard to get into, requires specialist referrals, and patients often wait a really long time before they can have something documented that this might be a problem. And so the Nasaline test is great. Orthostatic vitals are great. And so we know how to do this at Northgate. A lot of our MAs have done this a number of times. If this is something that is of interest to you to do in your patients, please talk to Jody and myself. This needs to be scheduled in a very specific way in an appropriate clinical staff visit. But we can do it here, and it is really helpful, particularly for documentation if you're dealing with a workers' comp case or somebody needs work accommodations. What are we looking for? So under this orthostatic intolerance, this autonomic dysregulation umbrella, there's three main conditions that we think of: the vasovagal syncope, orthostatic hypotension, and POTS. Really commonly, we have patients coming into our primary care clinic saying, I have POTS. I really encourage you to take a look at how that was diagnosed and how it was worked up, because a lot of times it's not actually POTS. And this is really, really important. The symptoms are often similar, but we don't want to over-label somebody with this condition. And so POTS specifically, you are going to see a heart rate of at least greater than 30 beats per minute that is sustained. And there's no orthostatic hypotension, so blood pressure is not changing. The vital signs and symptoms will also improve immediately as soon as the patient lays down. And then the patients need to have these symptoms for at least 3 months, and we need to make sure that they don't have anything else that could be contributing to tachycardia. A common one I see is anorexia and anemia.
Thank you. So in the interest of time, I'm going to go fairly quickly over this next section, but I wanted to talk a little bit more about some of the options for treatment for orthostatic tachycardia, and then specifically talk about exercise and post-exertional malaise. There is a really nice treatment algorithm and a lot of resources that are on the Bateman Horn Center website. So this is Dr. Bateman's website that I think walks you through very clearly some of the non-pharmacologic strategies, which we always use first, and then some of the pharmacologic strategies, depending on what someone's blood pressure and heart rate are doing. So I just wanted to make sure that you're aware of these. This here with this QR code is a link to a document that really goes into detail about orthostatic intolerance and a lot of the treatments that are available, including the rehydration and hydration and salt recommendations, which I think are really helpful. And then I'll just mention when we think about orthostatic intolerance and a lot of the symptoms that people are experiencing, there's a lot of overlap with chronic fatigue syndrome, ME/CFS, and many of the patients actually meet the diagnostic criteria for ME/CFS as well. And then one of the most common things that I think people really struggle with, especially in terms of how to get people to resume activities, are when people have post-exertional malaise. So I just wanted to bring this up for a couple of moments to talk about this specifically. So post-exertional malaise really is when people experience malaise or aggravation of their symptoms after they exert themselves, either physically, cognitively, or emotionally. And this response is delayed. So it's usually the next day, and it can last for 24 hours, 48 hours. I've had patients that it can last for several months. So it can be very severe after exertion. And the key thing is that it's out of proportion to what you would expect from that level of exertion for people. And it is unique to ME/CFS and long COVID. So it's really pathognomonic for ME/CFS. One of the scales that I think is one of the only scales that's out there that can help you to diagnose this with a standard questionnaire is the DSQ PEM, which is what we are using in the RECOVER trial to diagnose people with PEM. So I think the criteria here is not important, but that is a resource if you're looking for some standardized way to diagnose PEM. The most important thing, I think, is to ask patients about this, because we frequently don't, and then we miss it. And then we send them to physical therapy with no specific instructions about how to manage exercise. and then they start developing post-exertional malaise, and then they drop out, and then they just continue on this path of disability and lack of activity. So I did want to just point out that there was a recent study that has looked at muscle function in people with post-exertional malaise, and was able to really show through muscle biopsies and doing cardiopulmonary exercise testing that people with post-exertional malaise actually do show physiologic changes. They showed decreased VO2 max, decreased peak power output, gas exchange thresholds. When they looked at the muscles, there was clear evidence of inflammation in people with post-exertional malaise. So it's just another piece of evidence that really shows us that this is actually real and people are experiencing this. One of the most common and most important things I think to educate patients about is pacing and the 4 Ps of energy conservation, especially if they have post-exertional malaise. So there's a lot of controversy out there about exercise, and particularly with people with post-exertional malaise. I just want to say from our experience with exercise, I do think it is possible to get people back to exercise, and I do really encourage that, but I think it has to be done very carefully. I tend to avoid any kind of high intensity aerobic exercise or strength training because that's pro-inflammatory. There's been a lot of backlash about graded exercise therapy where you're continuing to increase the amount of exercise that you do despite the symptoms, because people can get worse after that. So it's really important that patients engage in the right kind of exercise. And this is where working with a physical therapist who understands long COVID and post-exertional malaise can be very helpful. Okay. So I think in the interest of time, I'm going to turn it back to you. There are a lot of resources for how to actually educate people about pacing, and happy to talk about that at another time.
We talked about most of this. So I did just want to bring up the grant again, because this is very relevant to primary care. And mostly I want to highlight this is a multidisciplinary effort with internal medicine, family medicine, rehabilitation medicine, neurology, rehab psychology, among others. It's an awesome team. There are 3 aims to this grant. I want to just highlight the sub aims under these aims that are most relevant to you. So we are aiming to improve the overall care delivery and improve access. We plan to extend referrals soon, including to Alaska. But what's more exciting in the more immediate future is that e-consults will be a thing soon. I don't have an exact timeline, but hopefully in the next year. We are hoping for that. So that's exciting. And then people are always asking me, how can we get involved in the community? We do a number of community events, and any of our residents and faculty are welcome to join us on these with these efforts. There are also a number of publicly accessible educational webinars that you can mention to your patients. And then the educational tools that will be available at some point. And then the third aim is to train people across WWAMI for caring for this condition. And something that we are going to be starting in the more immediate future next Monday is office hours. So please take a picture of this QR code and keep it, because instead of sending me curbside consults through Epic or finding me in clinic on a Wednesday, this is the best way to go about getting your questions answered now. And this can be used for anything from, I'm not sure if this person might have long COVID, or I'm not sure how to do the lab workup, or how to counsel, or I have a case to discuss, or pretty much anything related to long COVID. You can feel free to use this tool, and we will help you. So Mondays at noon. There's a number of ECHO series. I mentioned the one that I'm currently in, the pediatric long COVID ECHO series, and Dr. Friedley has been involved in teaching in one of the ECHO series for fatigue in long COVID for the last couple of years. And so these are excellent educational resources for you, and you can get CME credit for them. And then I've received some emails recently about, should I go to this? And so some of you may have seen the Long COVID Interest Group partnership with Department of Health and ACP. Dr. Anita Chopra leads these webinars, and they are awesome. So, and they are open to you. And so just quick summary, remember to validate, be transparent with your patients, and gain comfort with that discomfort of making the diagnosis, practice strong clinician stewardship, and try not to see these patients in short visits. They really do deserve longer visits with you, and making sure that we are appropriately involving our behavioral health colleagues. And then this is just a summary of all the resources we discussed for education and counseling, accommodations, and research and management strategies, all of which our clinic is happy to help with as well. And then I do a lot of research, and while people typically think of me as a researcher, I am a clinician educator and do rely on teaching evaluations for promotion. And so please do fill out a teaching evaluation for me if you get a chance. I would appreciate it. And we are happy to take questions in the 1 minute that we have left. I'm sorry. And then also the office hours tool is great to use for questions. That is not an easy answer. Long COVID, it was defined by the public, and that technically is like the most patient-centered term to use right now. But the more technical term I would say that we utilize is post-acute sequelae of COVID-19 and is used more in research. But long COVID is fine. We're using it more because patients, that's what they identify with. So the question was about pain and long COVID and how common that might be. So we do find that it is pretty common. So 88% of the patients referred to our clinic report having had pain in their acute illness. And then the majority of those patients continue to have at least one pain symptom. And there's a fair amount that have actually more than one pain symptom, even upwards of 3 or 4 pain symptoms. Yeah.
We have been using a fair amount of fatigue and brain fog. That's been pretty helpful. That's been very helpful for patients.
We also find that it can sometimes help with brain fog and fatigue. Yes. Yep. Yeah. Yeah. The work with NASM is one. And I think research and clinical care and the work with NASM need to all come together, which is what they're trying to do. Soon, yeah, soon. Yeah, so that's a good question. It's about the NASA lean and doing it in a clinical staff visit. That's why I said conversation has to happen with Jody, because typically it's not in a classic 15-minute block of time. It does require 20 or 25 minutes, and usually she will schedule these at the end. And so it's typically worked okay. And we don't do these really commonly in clinic because we can get what we need from the orthostatic vitals in many cases, but usually talking to her in advance is the way to go about that, because the special visit can be set up for it.
data. We have a number of dot phrases that we use that are dot post-COVID, and so we use those frequently. We are about to update those as well. But that's a great idea to develop that as part of the toolkit. That's one of the goals for this grant. It's really to help provide as many tools and resources for you all in primary care to be able to manage these patients. So that's a great suggestion. Mm-hmm. Mm-hmm. Yeah, so great question. And I think one thing to keep in mind is that disability forms were not created by anybody who understands disability in any way, shape, or form. So I'll just say that I've been doing this for 20 years, and this is all I do, and they're incredibly difficult to fill out because they make no sense. And it's not you, it's the forms. So just throw that out there. But the things that I will frequently use for patients that are really struggling and trying to figure out how to do that. Physical therapy assessments can be helpful to document some of the physical capacity sorts of questions. I do use neuropsychological testing that we offer in our clinic that can be really helpful to inform what people's strengths and weaknesses are for return to work. Our neuropsychologists are working on creating a short battery and testing that specifically in long COVID so that it can be reimbursed, but that it's not as cumbersome for patients and doesn't run into the reimbursement issues. And then for people who have really significant exercise intolerance and post-exertional malaise or really struggling to figure out why they can't get back to activities, I have been using cardiopulmonary exercise testing, and that has provided a lot of good objective data. And so those are some of the things that I use to help support some of the disability paperwork when I need to. But ultimately, a lot of it is, based on patient report of what they're able to do and not able to do.
I think yeah. Thank you. Use those office hours. Oh.